All right, so we're going to be looking at some of our hematological disorders, right? So things that would be in our hematological disorders, which would actually be like anemia, DIC, and things like that. This is common things that you would see on a regular basis. Anemia is more common than you think. We have so many patients that actually have hemolytic problems. Some of the key things you want to think about with anemia is that we think about it with low hemoglobin. All right. With this, we look at low oxygen carrying. That is a sign, as well as people do have headaches, fatigue, and stuff like that. They look pale and things like that.
Where can I see it?
It's somewhere in the thing. Maybe it's not available for you. Let's see.
Thank you.
So when we look at it, we think about aplastic anemia, right? Aplastic anemia could be like a B12s. Your patients that have iron deficiency, a patient that has folic acid deficiency. Those are like, our vitamins, minerals, and stuff like that. And this could be related to malabsorption, okay? Then we have things that could be with the bone marrow and low production of things or a disease, a hemolytic disease that could cause you to actually have, with the erythrocytes. This is the hemolytic, right? So when you look at hemolytic reactions or hemolytic diseases, it's normally related to the red blood cells being destroyed or not enough being produced. So that's some of the concerns there, right? So when we think about manifestation, how does the person appear, right? We look at clinical manifestation. So we look from head to toe is our assessment, the presentation, what do they look like? When we tell people, we say, oh my God, this person has symptoms, right? They're pale, right? Oh my God, they look so pale. This is why, because they don't have enough red blood cells that's carrying oxygen to the body. Weakness, fatigue that they complain of, right? In some cases, people do have jaundice because it's red blood cell destruction, right? So like sometimes your sickle cell patients that are facing that challenge of destruction of the red blood cells, they present sometimes with that, jaundice or the jaundice in the eyes, right? Then we could see, changes as they present in their nails, their tongue, the palm of their hands and stuff like that. This could be some of the concerns, right? With the heart, there could be heart failure, as well as with the heart, they could actually be tachycardic, right? Because they don't have enough. So common things that you will need to look at, when you have patients with this would be really and truly what is taking place. They cannot perform as they normally do. They don't want to get up and walk. They don't have the strength. They're at risk for fall. They become depressed. Sometimes what we call delirium, confusion, and things takes place. Then we think about, in the cardiac thing in a heart failure patient is being destroyed of the cells. They don't have enough. They can't meet the demand that the body needs. So these are some of the concerns, right? People with heart failure, sometimes it depends on the stretch of the heart. It could destroy the vessels and stuff because it's banging. High blood pressure also in severe cases. When this thing comes in, it could cause some drama with the cells because it could cause trauma. So destruction of the cells. The sickle cell disease is where, we could face more of it than others. Oh, I know she's not really eating a sponge. All right. We think about people's diet, their choices of eating could depend on also in relative, how do they respond, right? Key things to think about, if somebody has B12 and they're not taking supplements, their diet is poor, it's not going to help them, all right? Even if we give them the shot and whatever. If the person now had gastric sleeve, right? They could have malabsorption, which could cause them to have hemolytic reaction and stuff like that. Or they could be, just not absorbing anything. So then their B12, their folic, all that is off. Calcium, all that is off. Then we have to think about ways to give them that. people do better with the shot than the actual trying to take it because they're not absorbing. All right. So, what type of anemia would result from red blood cell destruction? Would it be bleeding, hemolytic? What do you think?
B, hemolytic.
Somebody was listening. I'm kidding. Yes, it's hemolytic. When they say destruction of red blood cells, it has to do with hemolytic, right? When it has things to do with, I would say, the ions, the folic acid, the B12, is normally what we call, pernicious anemia and stuff like that. Those are the ones that deals with all like electrolytes and all those ions. Sounds good?
Yeah.
All right. So, things that you need to look at, right? When we think about this, what tests do we need, right? So, what tests would you anticipate to measure these things? All right. Hemoglobin and hematocrit testing is part of a CBC, right? Total blood count. All right. We think about the erythrocyte or retic count and stuff like that. We want to be able to see that. We do this a lot in our sickle cell patient or thalassemia patients, right? We think about iron studies, B12 studies, folic studies. We think about bone marrow aspiration to look at that on the scope to see how much or if the bone marrow is actually shot, right? When we think about it, I would honestly, could go through CBC and go through the different things, how many platelets you have, how many things. I tell people really and truly, this is how you really got a lot of diagnosis from these tests. So iron, we definitely know when people have iron deficiency and stuff like that. But if they're taking iron supplements, one of the things it could cause constipation. So the person taking iron should take a Olace or a Senocot with this, right? Because they become constipated, as well as you expect them to have dark stool, right? So if you come in and you see dark stool, they'll be like, oh my God, it's melanoma stool. No, it's not, right? Do a little history taking, right? Especially when it comes to that. Let me see. When you think about blood cells distribution, we really don't do these tests unless you work in oncology, hematology. But it's a good to know. All right. Is when we do like manual diff and we want to see exactly how many red blood cells, how many there's under the microscope. All right. And that's per deciliter. So patients with anemia, what do? We assess, right? We assess our patients. So this is where we come in. Physical assessment, head to toe, history taking, weakness, fatigue, right? We also, people will be like, why we look at their tongue? Because the tongue has a big vessel, a lot of blood supply. All right? Say that again?
Cyanosis.
And you could look for cyanosis, but the thing about it with their tongue is going to be pale. All right? Even before the lips and the face, the tongue is pale. All right? So you think about your lab studies. You think about nutritional assessment. What is your diet looking like? How often do you eat? What does it mean? Then you think about medication that they're taking, because some medication could cause anemia, right? Think about cardiac disease, GI, and stuff like that. You want to think about hypertension, heart failure, these things. What's going on with the patients? Do they have GI loss? Are they somebody that's having frequent diarrhea, right? Do they have GI bleeds because they have ulcerative colitis or Crohn's, right? So this could actually cause them to be anemic, right? So this is something you want to think about. Neurological assessment as well. So as you look, right? Look at the tongue. The soft palate and all is pale. The tongue is pale. Under the eyelids is pale. It tells you, right? This person is facing anemia, right? In severe anemia, you could tell them from across the room. But in this case, you will tell based on these assessments, right? So key things to think about is how do we manage this? Management of this would actually be correcting it, right? Controlling it. So we might have to do blood transfusions for the person with low blood cell count, right, or white counts, right? and red cell count. We'll do packed red blood cells transfusion, so they could go to oncology, or in the hospital we could do it. If they iron deficiency, we have iron infusion. It's pretty painful, but normally they get PICC line to do it as well. And then we have the B12 shots, right? So we give them the shots. The shots works better, especially if they have malabsorption. You're not going to tell them take a pill every day and they have malabsorption. It's not going to work. And then you think about things. So sometimes when people go through treatments, right? So if you went through treatments and you immunosuppress, right? Or if you want steroids for rheumatic disease for extended period of time, you may face some of these challenges. So that's where we try to kind of stimulate the bone marrow, right? A dialysis patient might need to get the hypopiesis shot to stimulate, to produce red blood cells because of that, right? So these are some of the key things you want to think about. When you think about iron deficiency and things like that, you want to think about it as one of the key things you want to think about. So what do you want to look at? Iron, right? Where do we get iron from? Our foods, right? Some people take supplements to try to build it up, right? Key things to think about. What are you looking at? We look at the person presentation. We look at their labs. We look at them. What is going on? All right. Your assessment is what's going to trigger what we do. Now, key things to look at when we do our CBC, we're going to actually see that our hemoglobin or hematocrit is also low. All right. Because iron binds the hemoglobin, right, to help carry. All right. So then we have our oxygenation problem. Sounds good? All right. So key things: iron deficiency, oral supplements, IV if it's extremely low, right? It takes a couple of weeks for it to really get to the level. All right. Then dietary education is a big thing. Then we think about what's the best way for absorption and things like that, which is great. As well as we think if we want iron to absorb, we need to give what? Vitamin C. Yeah, orange is vitamin C.
Yeah.
So we do vitamin C with it. So sometimes you might see, they'll be like, why is this person getting vitamin C and stuff in a nursing home or anywhere? It's because of that, right? They give 500 milligrams of vitamin C with the iron supplement. Helps with absorption. All right. Of course, the side effect is dark stool, as we discussed. Constipation, a big one. So make sure they get a Seneca. All right. Our patients with renal disease could face it, as we say, our dialysis patients could have these challenges. Now, when we think about aplastic anemia, it could be damaging to the bone marrow. It could have been that you went through a bone marrow transplant. You could have gone through chemotherapy. You could have been on steroids for an extended period of time with rheumatic disease, right? So sometimes people with rheumatoid arthritis could be on steroids for a long time, and this could cause them to have aplastic, meaning that it shocked the bone marrow, so it's not producing as it should. All right. So we could have thrombocytopenia, which is the platelets count is low. All right. Neutral is the white blood cells, right? Your fighter cells, your neutrophils. All right. And things like that. So it could be a lot of that. When somebody is neutropenic, if you're sick, we don't want you in that room. All right. Because they have no real immune system. Sounds good? All right. So folic acid. When we think about folic acid, we need this. And a lot of times, mostly our pregnant patients would need this to help to build with the baby's spinal cord and tube loops and stuff like that. Now, in our case, you need it for your myelin shields and your neuro. All right? This helps with that. Now, it is really a concern with B12 because that's what gives you energy. A lot of times people are like, oh, what is B12 for? Vitamin B, the vitamin. But you would see the difference between the person that comes in and you start the treatment and you see their energy, they build up and stuff like that, and utilizing their muscles. It It takes a real toll on them. All right. Now, malabsorption from GI surgery, right? A sleeve could put them at risk for this. This is the biggest risk. And then pernicious anemia, whether the person had treatment or whatever, this is what helps them. Normally iron supplements work better, and things like that. Anything else? Questions about that? All right, we can move on. Hemolytic, right? Hemolytic really has to do with the destruction of the red blood cells. This has to do with whether it's a heart failure disease problem or it could be spontaneous, right? And it could be related to kidney disease, right? So you're going for dialysis. A lot of people are like, oh my God, they're on dialysis, but their counts are so low. It's because sometimes the filter and all that, and then the kidneys, it destroys the blood cells. All right. As well as that's why we give them the EPO shot. This will stimulate production. All right. So sometimes you're like, why they need this shot? Is because it will cause them to have anemia. So we want to stimulate it. Sickle cell disease. All right. You know, the cell is sickle. It also then gets destroyed sometimes with the passing through the capillaries. So this could be a challenge and things like that. Right. Then they worry about glucose force and things. I have never seen this defect in my life. Doesn't mean it doesn't exist. It's just not in our area. All right. But it exists somewhere. All right. More than likely, if you work like maybe Sloan or one of them, you might see this, which is our oncology hospital. But we don't see this in regular practice often. All right. So this is just one of the key things you want to think about. When it comes to sickle cell disease, you know, a lot of times this get kind of wiped under the rug. Oh, they're a sickler and stuff. They're in pain, give them some meds. But what is really going on with these patients, right? Their cells are sickle. It has that sickle shape and it's not easy to pass through the capillaries. It could occlude and cause clots or buildup. And that is where ischemia in that area could cause pain. They could lose their leg or their toes or limbs because of that. All right. It is extremely painful. Now, sickle cell with fever is even more dangerous because more than likely it's an infection plus they have in the sickle cell crisis, right? So this is where the red blood cells now could be in their lungs. Now, acute chest is like a pneumonia for sickle cell patients. All right. It's the most vulnerable time. This is where you could lose them if you're not there. So sickle cell with fever is very important. Blood culture, antibiotics, fluids, and stuff like that. Maybe exchange transfusions, right? This is where we would have to call in the people to actually give them what we would say is the exchange transfusion. So they literally pull out their blood and add new ones. All right. It's pretty interesting. It's a cool job. It's done by a nurse. You just gotta get trained, yeah. It's pretty interesting.
So
You could travel and do that, different states.
so they're gonna put the patient blood
They put in a
like at
central
the
line.
same time and they put in new
Yes. Yeah. So it's like a dialysis. So they're pulling it out
blood.
and then they're giving you it. It's an exchange transfusion. Like a kind of washing.
Oh.
Yeah.
The blood type has to be
It's plasmapheresis.
The blood type has to be similar to the patient.
Yeah, so the machine is doing it.
Oh,
So you hook it up as a machine. Yeah. It's plasmapheresis or apheresis.
How is it complicated? Is it does it have any side effect?
Everything has side effects. Risk for stroke, risk for bleeding, and stuff like that. But it's better than risk for dying.
Yeah.
You know? Weighing the risk and the benefit. So you have to think about, do you want them to die or do you want them to make it and then, have mild complications, So this is what it is. Because remember, if they do nothing, they'll die. Right? So do you want to live? Right? So it's things like that. So this is what it is. So of course, when it's supposed to go through the capillaries smoothly with a sickle shape, it can't. So it will build up, occlude it. It causes ischemia. That's where the pain really comes into play. They could get infections. All right. and stuff like that. They could become dehydrated and stuff. So sickle cell, one of the greatest risks for a sickle cell patient is actually stroke. You know, a lot of times people are like, oh my God, how did this 9-year-old have a stroke? Sickle cell. Because it had fluid and it was in the brain where the capillaries and the oxygen and it causes that. So that's one of the key ones. Yes, ma'am.
My understanding is, you know, they're going to start to shift
Your cell, the red blood cell. That's one.
Majority of patients that who have sickle cell, what do they come in with both? Is it
Pain.
because of the pain or is it because of breathing?
Pain. Pain. When they have fever, that's when we do the X-ray and the blood cultures and everything like that because we're looking for acute chest
Okay. So
and
in
stuff.
that case, the last stage, would it be the breathing that's the problem? Or
Well, it depends on what's going on with them, right? If the pain is chest pain, right, and they don't have fever, it could be where that cell is, that where the sickle is and the occlusion of that area is in the chest, right? It could be pulmonary. Doesn't mean they'll come in with pulmonary problems all the time. A lot of them, they say they get pain in their hand, their joint, their knee, back pain. It's just that those sickle cell occluded cells, the sickle cells that are stuck and occluding the capillaries are in that particular area. So normally where it's pain is where that takes place. So sometimes you see them coming with back pain, foot pain, you know, stuff, headaches. Then when we get headaches, we like, oh my God, are they stroking, right?
Good.
None is good. Because remember, ischemia means death of cells. If it's severe and we don't fix it, this person could lose their limb. They could have a stroke, could lose their toe, you know? So it's pretty challenging. That's why we keep them hydrated and stuff like that. We tell people hydrate yourself and stuff like that. You know, when you're sick, make sure you go to the doctor because it's all these risks that could take place.
Okay.
Yes.
Although they have like something, for example, if they have the pain before they went to the hospital, do they have something to take that's gonna relieve the occlusion or just
Yeah, because you need IV. More than likely it's dilaudid and stuff like that, which is IV drugs. Yeah, to give them. And if they've been, if they're having frequent crisis, remember they build tolerance. So we might have to have certain combination of meds. You can't give them regular perks. Like we give you 2 milligrams of morphine, you knock out. Them, we might have to give them 6. Right? Yeah. Because they've been getting these meds and it's not going to help them at that level. Yeah, and how long they've been in pain, how frequent they need to get it. That's why you do the PCA pump a lot. Post-op patient and sickle cell patient get the PCA, patient control, analgesic medication, right? You guys did PCA or no?
Yeah,
Okay. All right. So, nursing, when we care for these patients, we got to really pay close attention to them, right? So when we do assessment, we want to know what's going on with the patient, right? So we're looking at history, we're looking at physical assessment, looking at pain assessment, right? We're thinking about lab data, right? We want to think about, okay, how is the hemoglobin? Because we might have to give the fluid and transfuse before we even worry about the antibiotics, right? That might be more urgent than the antibiotics, right? So we had to think about like what is first. Then you think about the crisis. What would have been the trigger, right? They went to summer rave. They've been outside all day. They become dehydrated. They did them in, right? That's like a diabetic that, they wanted to get to the party early and they forget their insulin at home. And then when the party's over and they had a couple of drinks, they become DKA, right? So these are some of the things you have to think about, right? And especially the teenagers, right? It's not high priority, right? The party is high priority. My friends are high priority, right? So these are the things you want to think about. A lot of times the ones that we see are normally our teenagers and stuff like that. And then we have 1 or 2 adults. Sickle cell patients are now living longer. I have one that's 60 something years old, but normally in their 20s and 30s. Normally, they had stroke, they died of it. But management, if they take care of themselves, they do better. All right. So we control their pain. That's one of the big things, right? And things like that. All right. So key things. These are some of the complications, right? So poor perfusion to that area. Look how the foot look black. It looks like PAD, right? Peripheral artery disease or peripheral vascular disease. That's what it looks like. But really and truly, this could be a side effect of their disease, right? So pulmonary hypertension is very common with our sickle cell patients. Risk for stroke. They could have their respiratory disorders. Again, if they got issues before with that, the kidney, the spleen itself sometimes get inflamed. So sometimes they do remove their spleen and stuff like that. And then, of course, we could have necrosis of the bone because of poor perfusion to the bone. The liver could be compromised, as well as we could have ulcers with poor healing because of poor perfusion to the area. It's a painful disease. Yeah, it's a lot. Sometimes, unfortunately, it's a lot of infusions. All right, they could go for a lot of pain meds and stuff like that. Once they have a regimen, they do much better. All right, and then they're at risk for infection. Now, there is a treatment like stem cell transplant and stuff. It doesn't work for everybody, but I have a patient that it worked well for. But then we have the side effects of these things, right? So we shut down your bone marrow, and then we try to match it as close as possible. So we might take like your siblings or your mom's stem cells, and then we infuse it and hopefully grafts, right? But this doesn't always work because you can develop other things, all right, from there, as well as the person we harvesting. If they have a sickness that we don't know about, is the thing. So the crazy thing that we saw was that it had a brother and a sister. He was getting the treatment and we got him prepared and we started to give her the treatment so we could harvest her stem cells. And then she had a heart mass that we didn't see on the x-ray. When we saw the x-ray, I was like, oh my God. And it's because she started to complain of chest pain when we started infusing. And we opened, she had a mass right on her heart by the aorta. So you see, sometimes these medications could cause stimulation of things. Because remember when we asked for overproduction of these cells, it actually so we couldn't even harvest her. She had to be rushed to Colombia for open heart surgery. Yeah. So these are some of the things. Thalassemia is very common in like Middle Eastern.
Home Care LLC. Payment method form.
Sorry.
Personal assistant.
So it's like sickle cell, but it's more affecting, South Asian, Mediterranean, Middle Eastern areas. All right. It is like sickle cell, and stuff like that. For some reason, I tell people we don't see a lot of it, thank God, because, we kind of get a whole of management or we actually treat these people early in the stages with good management, the hydrated, the diet or whatever. A lot of our patients that come in with sickle cell with crisis is normally the patients who are non-compliant. The compliant ones, you see them in clinic. All right. So that's the good thing about it. What else we could add to that? Mm-hmm. So, any questions? No. All right. So, things you want to think about is blood cancers, right? So, you'll learn more about hemolytic cancers next week. But some of the things, it all starts at the bone marrow. So, a lot of times we're like, oh my God, what's going on with these people? A lot of times it's related to everything starting in the bone marrow. So sometimes we have different tumors and things like that, and then it starts in the bone marrow. This is where it comes from, the red blood cells. And then sometimes it actually could be in the spleen as well. All right, where we store some of our white blood cells. Questions, concerns? All right, once it's in the blood, it's everywhere. Because the blood supplies the whole body. All right?
What provoked it, Professor?
What stimulates it?
Yeah. So what provoked the blood mark.
So,
Bone
one of the
marrow,
things is that
fluorescence.
everybody is born with these cells. Exposure sometimes trigger it. So you can be, say, you're born with this and you work in construction.
Mhm.
And then asbestos triggers now, and now you have a cancer based on that because of the exposure. You work in radiology and you decide that you didn't want to wear the sheets all the time. Continuous radiation over a period of time then stimulates the cells. So we had a couple of times. So what was it? So for chemo, for example, 30 years ago, nurses used to mix chemo like that, like regular meds.
Mhm.
Now, maybe 10 years ago, they find out, hey, this should be under a vent in a lab. People should have a mask on because the people that did that, they became sterile. They developed cancers. They did things because of that, right? So the stimulation of these things cause it over a period of time. All right? Any questions about that? This here, you don't need to know. All right? We're not doing the study of blood cells and stuff like that. Okay? Now, this is a big and common one, is neutropenia. Neutropenia is when our neutrophil count is so low that we had to put them on reverse isolation. All right, reverse isolation means that you will get them sick. Right? This is where we have neutropenic patients. They're not allowed to get flowers in the room in the hospitals. We're not allowed to carry fruits that are not peeled and things like that. You got to put on booties and gown and mask to go into the room because any little organism could get them sick. They have no defense, right? And this could be related to treatment. It could be related to a disease process and stuff like that. Sometimes it's unknown, right? The person comes in, they have neutropenia. You're like, what's going on? It's unknown sometimes. So this is where you see that neutropenic precautions and stuff like that. Some places put it reverse isolation and things. We don't allow visitors if they're sick and stuff, or you might see the nurse first on the door and stuff. So this is some of the blood disorders and stuff like that. Thrombocytopenia. This is very common when you see bruising that are of unknown origin. All right. This is where you get to say, okay, let's check their platelets, right? It could be other things and stuff like that. But when they think about it, it could like a purpura rash and stuff, as well as sepsis, which you're going to learn later in the semester. Sepsis could destroy some of your red blood cells and your, different blood cells on the whole, but it really could attack your platelets. And then sometimes this is what causes us to now have bleeding, right? And bruising and different things. So we do have Van Willebrand's, which is a disease. It also would affect like bleeding itself, but this is more of what I would say people are born with Van Willebrand's versus somebody could develop regular thrombocytopenia, right? Then we have our hemophilias, right? We don't have a lot of them right now because, of course, they die early, if not managed or caught early, right? Hemophilia is a genetic disorder, all right? It have different factors that it really comes into play with, and this is some of the challenges, right? So hemophilia, they come with their medication, their factor 8, their factor 9, and things like that. They could prepare it themselves. We teach them to prepare it if they have an episode prior to them coming. All right? They might teach you how to give them it. All right? Now, coagulation disorders, right? It have multiple things. The most common one is actually when we have liver disease patients. A lot of times people are concerned about the ascites and the jaundice, but they have high risk for bleeding. A liver patient falls, they could have a bleed out episode. A liver patient get cut because in the liver, this is where all the clotting factors are. That's why when a child is born and we give the vitamin K, it stimulates the liver to produce these factors. So this is where we have the problem. So I tell people also patients that are on heparin, right? You could have heparin induced thrombocytopenia, right? So that's why we used to use heparin flushes, the hep lock. We stopped using it, right? We only use heparin for central line and ports. No. We used to use it for everything, and then we realized it causes thrombocytopenia. All right. Any questions about that? All right. Now, DIC. This is where your body itself is now making clots, all right, inappropriately. It's common in sepsis. It's common in patients that are oncology patients and they become sick and they have tumor lysis syndrome. All right. This is where the disorder, meaning that all of a sudden you have a clot in your kidney, you have a clot in your lungs, you have a clot. Yeah, it's releasing a lot of your factors and it's creating clots in inappropriate areas. So in this case, people want to know, what are we doing, right? Your body now is actually creating this. We had to start heparin. Heparin is going to actually thin the blood. And people are like, what? We have a bleeding problem. Why we give heparin? Heparin is actually what's going to make it stop getting bigger, the clots. But we're going to give you replacements. It's very odd, right? Because now you're clotting, but we're giving you platelets because your platelets are low. We're giving you cryo, which is plasma spin down that has more factors in it. We're giving you red blood cells because you're clotting and stuff. DIC that's caught early, you could survive. If you miss it, there's no turning back. You can't. All right. More than likely, these are in our trauma, our sepsis, our shock patients, our cancer patients, of course, and things like that. It doesn't have a good outcome. You'll be chasing your tail. I had a 16-year-old. She went to sweet 16. She got sick. Then she came to the hospital. Then she was brushing her teeth and she just see like blood coming and just couldn't stop bleeding. When we started go and do stuff, we realized she actually has cancer. Right? At 16. It's crazy. Then we start the treatment and they got her first dose of chemo. She went into DIC. I was chasing my tail. I couldn't get an IV on her. I had ultrasound lines. And we were chasing. 8 hours we worked on this girl and she still died. It was crazy. And the bad thing about it is I knew her aunt. I used to work with her aunt in the nursing home. So I'm like, oh my God, I felt so bad. I was like, this is crazy. You get sick, you don't know you're sick, and these things, and then you start the treatment that's supposed to help, but then your body reacts, causing DIC. Alright? This is the pathophysiology behind DIC. A lot of times you will hear about we checking coag studies, fibrinogen. Alright? We're thinking about, PTT, APTT. So APTT is what we use to monitor heparin levels. PTT and INR is the same test. Alright? For like warfarin and stuff like that. And then we have fibrinogen, which will check your fibrin. Right? And stuff like that. Alright? For other tests like factors tests, we had to get that ordered specially. Sometimes we can't even order it. We had to call the lab and they will have the approval to run it. All right. Now, if we don't act quickly, and is either the person bleed out or they have organ failure. All right. So if you're going to be an ICU nurse or an oncology nurse and you start in treatment, you can't say, all right, let me take my phone call or let me chill or let me watch a movie because this patient here, outcome depends on you. All right?
Question.
Yes.
You said if you don't act quickly, what time do you get to that?
It doesn't have a time frame because, again, if the person didn't bleed, doesn't mean they're not making clots. You have to see the change, right? So the person now, the foot is cold, right? Or perfusion. Pulse is diminished. Poor perfusion, right? Blood pressure is dropping. Poor perfusion, right? So you might not get the signs of just bleeding with DIC. You're monitoring. And that's why I tell people, right? People like to come in and they do one assessment for their shift. And then they think, all right, I did one assessment, but when are you reassessing? You give a blood pressure medication. Did you go back and do vital signs to see if the blood pressure medication worked? They'll be like, but I have 6 patients. I said, but you gave a medication. Did you make sure it's working? or is it hypotension, or do you want to wait for the patient to fall out of bed because they're hypotensive, right? So these are the key things, people don't understand. As well as you give Lasix, did you make sure they pee, right? Did it work, right? If it's not working, then hello, what's going on? So these are the kind of things we need to be constantly on the move. So if you're not monitoring them, that's it. That's why I tell people we have clinic nurses, we have OR nurses, we have things. You do what you like and stuff. Some people they like all the surgical stuff, great. Then we have people who like ICU, and they like their two patients that they monitor throughout the night, or their one patient, depending on how sick they are. And then have people that be like, you know what? I would put my lines, I would put my stuff, I'll be in ER, I want to get this, I want to discharge them, I don't want to take care of them for 12 hours. That's your choice, right? Or the trauma alone, right? So it's their choice, right? So this is just some of the clinical manifestation and stuff like that. Like what I think this is the data as well of like, how much percent of the clinical manifestation would be bleeding. Of course, bleeding is the highest one. Then we have the renal dysfunction. We have, of course, the hepatic dysfunction is 19%. Respiratory dysfunction would be 16%. Shock, thrombosis or thromboembolism is 7%, and then neurological is only 2%. So if you like neuro and stuff like that, you can do it. So this is a cool video. It doesn't work on the PowerPoint unless you break it down. That will tell you a little bit more about DIC and things like that, right? Interventions. All right, nursing care. What do? We had to treat the underlying cause, right? So if it's sepsis, we make sure we do antibiotics, we do all the care, we do all of these things, right? We evaluate the vital signs, okay? What do? Blood products, right? Because they bleed in, they clot in, all that is going to drop your levels. So you got to replace it. Fluids. Heparin. Heparin is really to actually stop or interrupt the clotting, but it's not going to break up the clots. All right, we'd have to do like fibrinogen stuff to break it up, which would be like a TPA and stuff like that. No, you're bleeding already. We can't give you TPA until you stabilize. Or we had to do that. All right. Questions, concerns? No? Yes? Maybe so? Fine. I'm kidding.
For DIC, you said that the